Greetings and salutations again, everybody. Our talk here is going to be on contraception. Now, there is a little bit of irony here in me being a Roman Catholic giving a talk on birth control. But here we are, and this is a pretty important topic to be aware of because there are going to be a lot of women that come to you asking for birth control. And there are various methods, not just the pill. There are lots of different ways that we can do birth control, and figuring out the right one is going to depend on the woman and how reliable she is to either take pills or whatnot. Okay, so we're going to start. These are divided up into how effective they are. And then from there, you can determine how reliable the woman is, and if you want to go towards maybe one of the more long-acting methods, or if you want to go towards pills. It really is a matter of personal preference for the patient. So we're going to talk about the most effective ones first, namely the intrauterine devices and the Progestin implants. We're not going to talk about, I just put this here for completion's sake, but we're not going to talk about the sterilization techniques. That's going to be tubal ligation and then the male vasectomy. We're not going to talk about those here. And then the second tier, which are considered very effective, that's probably the most common, which is the oral contraceptive pills. That's divided up into the combined oral contraceptives, which have both an estrogen and a progestin component, and then the progestin-only pills, which only have the progestin in it. We'll also talk about the injectable progestins, which is pretty similar to the progestin-only pills. It's just that these are going to be injected, as the name would imply. And then there's patches, and that's a progestin-only method, and then the vaginal ring, which is going to be an estrogen and a progestin. And then we're not going to talk about this here. I'll save this for another lecture, but these are effective, but less so than these medical techniques, and that is the barriers, which you can imagine the most common is going to be male condoms, and then natural family planning. Now, if you work in a Catholic hospital, which there are a lot of in the U.S., natural family planning is going to be pushed because with the teachings of the Catholic Church, artificial contraceptives are not permitted. And so I was trained at a Catholic hospital, and you were not allowed to write prescriptions for any of these things on the hospital's notepads, on their prescription pads. And we don't use those really anymore. It's done by computer. So you would actually have to write it out on a blank prescription pad. But anyhow, you might run into that. And so when we will talk about natural family planning in a separate section, because some women will prefer that because of religious issues. So it's good to be aware of that and how that's done. And actually, natural family planning is a pretty effective way. And you don't run into all the side effects that you can run in with these. And the side effects are not negligible. Okay, so first we're going to talk about the IUDs, or intrauterine contraception. Now, one of these is called an IUS, intrauterine system. The other one's called an IUD, intrauterine device, but they really are the same. So there's two of them that I want to talk about, and the first is the levonorgestrel releasing intrauterine system. This is marketed as Mirena, and Mirena is, it only releases a progestin, and that progestin is levonorgestrel. It releases it at about 20 milligrams per day and renders the endometrium atrophic. It also stimulates a thick cervical mucus, and it reduces tubal motility. Now, the problem with that, when you reduce the tubal motility, is that the egg may not get as far down as we would normally have it, and so you can get fertilization further up, and you can have implantation in the fallopian tubes, and therefore the Mirena actually increases the risk of ectopic pregnancy. Now, with Mirena, if you're using it, you're not going to be ovulating as much. And so the overall risk for an ectopic pregnancy goes down because you're not ovulating as much. But if you do happen to ovulate and you do happen to have fertilization, in that case, then the risk of ectopic pregnancy goes up. Okay, so hopefully that makes sense. The overall risk of ectopic pregnancy goes down because you have less ovulation, but if you do ovulate, then in that case, you're more likely to have an ectopic pregnancy. Okay, so you put this in, and you can leave it in for up to 5 years. So that's really nice because you're not taking pills every day. Okay, the other one, this one's slightly older. This is a copper T380A intrauterine device. It's marketed as Paragard. And this one, you're not using hormones. So the nice thing about that is we're going to see with a lot of these contraceptive methods, devices, pills that have hormones in them, which is pretty much all of them except for the copper Paragard. There's various side effects which can include increased risk of certain cancers, weight gain. And so with the copper T380 intrauterine device or Paragard, you don't run into that. So that is one of the benefits of this one. Now the copper itself is going to elicit an inflammatory response. It activates lysosomes, and that's going to have some spermicidal effects, so it works that way. If conception does occur, then those inflammatory actions are going to be directed against the blastocyst. And then it does also, by virtue of the inflammatory reaction, it does induce some changes of the endometrium. So that's how it works. It doesn't really do anything as far as ovulation goes. This is not hormonal. This is just going to render an inflammatory reaction, and so you get some spermicidal action there, and then anti-blastocyst activity. Okay, so this one works a little bit differently. You put it in, it lasts up to 10 years, you don't have to take it out. What are the contraindications? So these ones that are starred here are going to be absolute contraindications. So if the patient is pregnant, you cannot give either of these, obviously, because if the patient is pregnant and you stick this IUD up into her uterus and it's got all these hormones, it's just going to screw up the pregnancy. So you want to make sure that the woman's not pregnant before you apply one of these. If there's vaginal bleeding of unknown etiology, that goes for any of the IUDs. You cannot give it in that case because we don't know what it's coming from. Is it coming from a cancer? Is it coming from a pregnancy? We don't know what it's coming from, so we want to figure out what that is. So if she's having bleeding, we want to know, is it maybe it's from her period, maybe it's from something else. So we want to get to the bottom of that before we put an IUD in. If there's an active infection of the reproductive tract, you're going to need to treat the infection first before you put the IUD in. If she has a history of an ectopic pregnancy, that's considered a relative contraindication. So you may or may not do the IUD in that case. If there's a history of an STI, really worried about possibility of a subclinical acute infection. And then if there's any kind of anatomic anomaly or fibroids, and the reason for that is because you may place the IUD and you might get it in there, but these are designed for normal uteruses. And so if you place the IUD and you get it up there, but she has an abnormal uterus or she has a lot of fibroids, you're going to have a higher risk of the IUD spontaneously dislodging. And if that happens and she doesn't notice it, and then she can get pregnant because it's no longer there, no longer working. Okay? With the Mirena, we cannot use it if she has current breast cancer, and that's because you have, and that's going to go for all the other hormonal contraceptives, breast cancer can be sensitive to estrogen and progesterone. So if she has a current breast cancer, you cannot use the Mirena. You can use the Paragard, however, because that's just copper. Now with the Paragard, you can't use it, of course, if there's a copper allergy, if she has Wilson's disease, not a common disease, but if she has it, then you can't use it. Or if there's menorrhagia. We don't want to induce inflammation if there's menorrhagia. Okay, so some other things with this. Regarding the IUDs, if there is infection, we can't use it if there's active infection. There was concern about the possibility of increasing the risk of developing an infection by placing the IUDs, and that really doesn't happen as much anymore. The risk has improved with improved device design, as well as just the overall the structure of the devices. We're going to look at that in a little bit. When they used to put the IUDs in, they used to give prophylactic antibiotics. You don't need to do that anymore. Fewer than 1 out of 100 women that have an IUD placed will develop an infection within 20 days. Okay. There used to be also some concern about placing these in women with HIV. You can do that. You don't have to worry about any contraindications there. Now, I don't have it. Okay, so side effects. I just wanted to bring up some of the side effects. So with Paragard, you can develop dysmenorrhea while it's in. Usually that will go away with time. So usually with the Paragard, you will give an NSAID before you place it, and then you'll send her home on a prescription of NSAIDs. She could probably just take something like Midol, because there is a dysmenorrhea is one of the side effects of Paragard. You can also get a slight menorrhagia as well, but that does tend to be self-limited. And then complications. Actually, I think I do have it here. Okay, so anyway, we'll get on to that. But okay, so this one, you can see they look a lot alike. This one on the left here is the Mirena. We'll have a little tube that this kind of sits in, and then you place it up until you get to the top of the uterus and get a little bit of resistance, and you pull it out, and this sort of T forms, and it lodges into the uterus that way. This one in the middle, I'm not sure what one that is. It's not a Mirena. This one on the right here is the copper T, and you pretty much insert it the same way. So you can see they're quite small. So the benefits of the IUDs, they're highly effective. It's good for poorly compliant patients, patients that probably aren't reliable to take a pill every day. They do last for a long time. The Mirena lasts for 5 years. The copper T lasts for 10 years. And then the periods may eventually stop or lighten. Now, the Mirena, because it has a higher propensity to lighten the periods, may be better for women that already have a heavy flow. And it also may be better for women that already have dysmenorrhea, because as mentioned, the Paragard increases pain with menstruation. The drawbacks to the IUDs is that there is a small risk of uterine perforation. If the physician who inserts the IUD is experienced, that risk is even less. There is a risk of spontaneous or silent expulsion, and so we recommend that women periodically feel their cervix. There's these little strings that are on the other side that should be coming out the cervix, so she's feeling for those little strings. If those strings are there, then we know that it is appropriately inserted. If the strings aren't there, then it may have came out. It doesn't protect against STDs, so the only thing that's really going to do that is the barrier contraceptives. And then there's the risk of dysmenorrhea with the Paragard. All right, I think that's all I wanted to talk about here. So the next one we're going to talk about is the Progestin implants. This is known as, one of them is known as Implanon. That's probably the most common one. There's another one called Nexplanon, but they really are the same, the same medication. These are subdermally inserted implants. They look like a little match, that you use to start a fire. That's about how big they are. It's just a single rod subdermal implant containing a progestin. known as etonogestrel, and this is covered in a polymer to prevent a fibrosis reaction. And they're placed right in the biceps groove. They last for about 3 years. And then because this is a hormonal method, you do have some contraindications. First and foremost is pregnancy. You also will not use this if there's a past history of thrombosis or thromboembolic disorders. However, that might not be a absolute contraindication because this is progestin only. Usually we're more concerned about this when we're giving estrogens. So I got this from the manufacturer, but for test-related purposes, we're more concerned about history of thrombosis or thromboembolic events if we're giving an estrogen, so like a combined oral contraceptive or a NuvaRing. We're not as concerned about it with the progestins alone. If there's a history of liver tumors, either benign or malignant, if there's active liver disease, or of course a history or presence of breast cancer. And then, as always, if there's any kind of vaginal bleeding of unknown origin, we're always concerned about giving hormones. Okay, so this is what it looks like. You can see it's very small, fits in the palm of your hand, and this is implanted into the biceps groove. So you can see here it's being done. The benefits to the progestin implants is that they are highly effective. You just put it in once and it lasts for a few years. This too is good for poorly compliant patients because they don't need to take a pill. There's less of a risk of expulsion compared to the IUD because this is inserted into the skin as opposed to into the uterus, which is open through the cervix. The drawbacks here is that there is an unexpected bleeding profile. You can get an expulsion. It is possible with these implants, but it is less common than with the IUDs. And it is more cumbersome to put in because, as you can see here, it's a little bit different than sticking something up the cervix. You have to puncture the skin and everything. So that's one of the drawbacks. But for the most part, these work pretty well. Okay, so this is the most common contraceptive, and this is the oral contraceptives. Here we're talking about the combined oral contraceptives. So not the progestin-only contraceptives. This is the combined oral contraceptives, which contain both an estrogen and a progestin. The way this works is essentially by inducing a pseudo-pregnancy state, and it interferes with the pulsatile release of LH and FSH through having the estrogen and progestin. You're interfering with the feedback mechanisms. And so that's therefore going to suppress ovulation. It also, by virtue of the progestin, is going to thicken the cervical mucus, reducing the ability of sperm to get up the female reproductive tract. And it also alters the endometrial lining, making it less receptive for implantation if fertilization were to occur. Now, there are two different categories that these combined oral contraceptives can fall into, and that's kind of based on the dosage of what the estrogen and progesterone, and that's going to affect how these are taken. So there's monophasic and multiphasic. So monophasic is the easiest, and that's how these are most commonly prescribed because it's the easiest for the woman to take. And it's very simple. What you're doing is traditionally you're taking the pill for 3 weeks and then a placebo for 1 week. And it's called monophasic because you're using a fixed dose. So for those 3 weeks, you're taking the same pill. And you take that for 3 weeks, and then you take a placebo. Why are you taking a placebo? Because it's easier for a woman to remember because she's taking a pill every day. She doesn't have to stop taking a pill and then start back up again. So that's why they do the placebo. But theoretically, you wouldn't have to do that. These are typically done 21 days, 3 weeks, and then 3 weeks on, and then 1 week off. However, there are some regimens where you do 24 days on and 4 days off. And that's done because you can reduce the number of bleeding days. And so if the woman were like anemic or something, or she has heavy bleeding, it can be useful for that. And that particular regimen, the most common one, is called YAZ. And YAZ is drospirenone ethinyl estradiol. That's not super important. But YAZ is also used for the treatment of premenstrual dysphoric disorder, PMS, and also for acne. And that's because of the progestin, reduces the amount of acne. You can extend the dosing days for women that you're using contraceptives for because of menstrual-related disorders. So here I'm talking like endometriosis, menorrhagia, anemia, dysmenorrhea, other menstrual irregularities, also PMS, polycystic ovarian syndrome, etc. In those cases, you can actually give them for much, much longer. So you can give even up to 60, 70, 80 days where you're using the hormonal pills, and then you can do the placebo for a few days to induce a withdrawal bleed. There's one called Seasonique, and Seasonique is levonorgestrel ethinyl estradiol. That's actually given for 84 days or 12 weeks on, and then 1 week off. And that's why it's called Seasonique, because you give it once every 4 seasons. So you'll take it and you'll go a whole summer and then go off, and then take it a whole fall and go off. So that's typically used, like I said, for those menstrual related disorders, particularly endometriosis is common, where you're going to give contraceptives to reduce symptoms. Okay, the other one is multiphasic. Now, with a multiphasic, you're taking different dosages each week, or you're kind of alternating the dosages. And the reason that this is beneficial, why you might want to do this, is because you're using less hormone in general. So you're exposing the patient to less estrogen and progesterone, and that therefore reduces the adverse effects. The big problem with this is it's much more complicated. So monophasic tends to be the way we go, but monophasic and multiphasic, you may be asked about that on the test. So you can see here, give these out once a month, and here it is, 28 days. And so it should be 3 weeks on and then 1 week off, and these are the placebos, and they're probably red because that means she's going to bleed during this time. These are the multiphasic here. You can see it can be much more complicated. I can't imagine it's super complicated. I mean, you just take this one on day 1, this one on day 2, this one on day 3. But these are going to be different dosages. Okay, now one of the big problems with combined oral contraceptives is that you're giving estrogen, you're giving progesterone, and there's contraindications. And most of those contraindications are going to be stemming from the estrogen component. So as always, if she's pregnant or if she's nursing, you can't give birth control pills. Now this relates to the estrogen. If she has a history of thromboembolism or pulmonary embolism, absolutely no combined oral contraceptives. If she has a history of coronary artery disease, if she has a history of stroke, no combined oral contraceptives. Estrogen raises your risk of all those things. Now, if she's a smoker, can we give oral contraceptives? And the answer is yes, if she's under 35. 35 or younger, I believe it is. If she is a smoker and she's 35 or older than 35, then you cannot give combined oral contraceptives. So being older than 35 or being a smoker, neither of those by themselves are contraindications, absolute contraindications. It's both of those together. So if you're a smoker over the age of 35, that's an absolute contraindication. If there's a history of breast or endometrial cancer, we don't want to expose her to these hormones. If there's unexplained vaginal bleeding, we want to know where that's coming from first. If there's abnormal liver function, we don't want to give these. And then severe cholesterol or triglyceride elevations, it has to be quite bad in order to for that to be a contraindication. And then some of these these ones here are relative contraindications. Combined oral contraceptives can worsen migraines. Seizure disorder, why is that? It's not because these drugs actually increase your risk of seizures. It's because the combined oral contraceptives can interact with the medications that are given for seizure disorders, particularly Dilantin, Tegretol, Topamax. It can reduce your levels of those medications, and so it can increase the risk of seizures in people who are taking medications for them. We do want to be concerned about this if the woman is over the age of 40, if she's got a high risk for vascular disease, let's say she's got angina, probably want to avoid it. And then hypertension and diabetes. There is some interaction with glucose metabolism, so it can worsen diabetes. But these are all relative contraindications. The one you want to be aware of for the test that I can see coming up very easily is that you have a woman who's 37 years old and smokes a pack a day. She cannot be on oral contraceptives. You have a woman who is 24 and she had DVT or a PE. No oral contraceptives. Okay, and these go for the combined oral contraceptives. So you got estrogen and progesterone. Okay. As mentioned, these are the complications. So we talked about these sort of thromboembolic, vascular complications, DVT, pulmonary embolism, stroke, heart attack, hypertension. And then down here, we have cholelithiasis and cholecystitis. So these can cause gallbladder problems. And then the famous hepatic adenoma. So you can have a woman who's got this hepatic tumor. It's totally silent. She doesn't know about it. And then she starts taking birth control, and she suddenly develops hypotension, tachycardia, passes out, and winds up in the hospital or dies. That's the hepatic adenoma. So you can have a hepatic adenoma. It's benign. It's not doing anything. And then you take the birth control pill, and it can cause that to rupture. Or it can increase your risk of developing a hepatic adenoma in general. Okay, so remember the association between combined oral contraceptives and hepatic adenoma. So the benefits of the combined oral contraceptives, they're highly effective when taken appropriately, but that's the operative phrase here, when taken appropriately. If she's not taking it reliably, then they're not going to be as effective. It does reduce the risk of certain cancers. So we've talked about all the bad things about these, but there are some good effects here. It reduces your risk of endometrial and ovarian cancers. It reduces your risk of osteoporosis because you're taking estrogen. Estrogen is protective against osteoporosis, and it treats a variety of disorders, namely, like we mentioned, endometriosis is one of the big ones. The drawbacks is that you have to take the pill every day. So it's not like the IUDs where you place them once and then they're there for 5 years. You have to take it every day. Preparations, particularly the multiphasic ones, can be confusing. There's, as mentioned, a long list of contraindications, long list of drug interactions. There is an increased risk of cervical dysplasia and cancer. It's still quite low, but there is that. There's an increased risk of gallbladder disease, increased risk of benign hepatic tumors, particularly the adenoma, and there's some side effects which really aren't that bad: nausea, headaches, breakthrough bleeding, and weight gain. And the weight gain really goes for any of the hormonal contraceptives, and it's not too much. I think 2.5 kilograms is the median weight gain. Okay, now the progestin-only contraceptives. Why would you want to use a progestin-only contraceptive? And the answer to that is if she has a contraindication for receiving estrogen, so let's say DVT, PE, history of a heart attack or stroke, thromboembolic disease. The problem with that is the estrogen. The progestin, not so much. So if she has those contraindications, she's 38 years old and a smoker, we can give progestin-only contraceptives. That's okay. So here we're talking about the progestin-only oral contraceptives. There are progestin-only contraceptives that aren't oral. We talked about one of those already, like the Mirena, it's levonorgestrel. But these are the progestin-only oral contraceptives, also known as the mini pill. This is just a small daily dose of progestin. There's no estrogen involved in it, but you have to take this every single day. Okay, so you're not doing a placebo week. You're taking this every single day. And that's one of the problems from this. So you have to take this every day. And not only do you have to take it every day, but you have to take it at the same time every day, because it only lasts for about 24 hours. So if you miss it, then it actually will render you fertile for 48 hours. So you have to take this at the same time every day. I think you can't miss it by more than 4 hours. The mechanism here, it's the same as all the progestins work. It thickens the cervical mucus and does induce some level of endometrial atrophy and interferes with ovulation. The side effects here: irregular ovulatory cycles, some breakthrough bleeding. It increases the formation of follicular cysts. You can get some acne and breast tenderness. The benefits to the progestin-only contraceptives, namely, they may be taken by women for whom estrogen-containing contraceptives are contraindicated. So women over 35 who smoke, women with hypertension, history of thromboembolism, vascular diseases, and nursing mothers. Now, here's the problem. These are not as effective. So if the woman doesn't have any of the contraindications for the combined contraceptives, we want to use those. Those are better. Okay? But if she does have contraindications, then these are certainly an option. These are falling out of favor because of the we're using the IUDs more. The Mirena gives you the same medication, but you don't have to worry about taking a pill at the same time every day. So we're not using these as much. And then irregular menses is another disadvantage. Okay, so hopefully you're getting an idea here of how these are very diverse and how different women, depending on their medical situation and their own habits, may prefer different methods. Okay, so here's the injectable progestin. So again, here we're talking about a progestin-only method. And the injectable progestin, the one that's most commonly used, and it's quite popular, is called Depo-Provera, or DMPA, which stands for dipomedroxyprogesterone acetate. And this is pretty effective, and it derives a lot of its efficacy from the fact that you don't have to be really religious here, because you're only getting this every 90 days, and then you don't have to worry about coming back for 3 months. So, as mentioned, this is administered intramuscularly, 150 milligrams of Depo-Provera. The failure rate is anywhere between 0.3% and 7%. Again, mechanism here similar to the oral progestins, and that is that it increases the thickness of the cervical mucus, making it more difficult for sperm to penetrate, and then it suppresses ovulation to a certain degree. The profile of adverse effects and contraindications is similar to the progestin-only pills that we talked about. The major one here that we are concerned about is bone demineralization, and that comes from the higher levels of progestin. So with bone demineralization, you get your greatest decrease within the first year, and then it does continue to demineralize with the length of use. And so there's a general recommendation that you shouldn't use this for more than 2 years unless other methods are inadequate. So, for instance, there's a contraindication to using a combined oral contraceptive. So that is the major hang-up with Depo-Provera. It is recommended, no matter how long she's using vitamin D, no matter how long she's using Depo-Provera, that she's taking supplemental vitamin D and doing some weight-bearing exercises, because that's going to reduce the degree of bone demineralization. ACOG does recommend that concerns of bone loss not preclude you from doing Depo-Provera if that is what you and your patient conclude is the best approach. So while there is bone demineralization as an adverse effect, ACOG is kind of telling you don't worry about it too much. But it is recommended that you take vitamin D and do weight-bearing exercises, and it is recommended that you don't do this for more than 2 years unless you really have to. All right, so the benefits here is that it is highly effective. You only need to get the injection every 3 months. It reduces your risk of endometrial and ovarian cancers. It is also useful in the treatment of menorrhagia, dysmenorrhea, and endometriosis, and it can be used in patients in whom estrogens are contraindicated. The side effects here. So you can get all sorts of weird side effects from these, and chiefly that's going to include irregular menses, but you can also induce depression, and so you want to use this with caution in patients with pre-existing mood disorders. There is a degree of weight gain that comes from this, as with all of the hormonal contraceptives, and it may worsen PMS and premenstrual dysphoric disorder. Bone demineralization, as mentioned, is a problem. There is an increased risk of cervical carcinoma in situ, but apparently not an increased risk of cervical cancer itself. And this is another one that you want to make sure the woman is aware of. So let's say that she doesn't want to get pregnant now, but maybe she's planning on getting pregnant 7 or 8 months from now. The problem with the Depo-Provera is once you give it, if she wants to get pregnant later on, it's going to take quite a while for her to start ovulating regularly again. It usually takes around a year for her to start ovulating normally again. So you want to make sure that if she's going to take this, that she's not planning on getting pregnant anytime in the near future. 3-4 years from now, fine. But if she stops taking it, she's still not going to be very fertile for a while. Median is about 10 months. Okay, so that's something to keep in mind. So this is the Depo-Provera, just a shot. That's all you're doing. Okay, now there's the patches. The patches have kind of fallen out of favor because there's been some litigation issues with it, but there really is no evidence saying that these are riskier than anything else. But the patch, and the one that's used in the U.S. is called the Ortho-Evra patch, which is norelgestromin and ethinyl estradiol absorbed through the skin. So this is essentially a combined oral contraceptive, just like the oral ones, but it's just absorbed through the skin. The adverse effect profile, the contraindications are all pretty much the same. So this is just a patch, and it's very similar to the pill. You give a patch. You don't have to apply a patch every day. You just apply a single patch, and it's there for 3 weeks, just like you take the hormone pill for 3 weeks, and then you take the patch off for a week. And that is essentially the same as your placebo period, and that allows for a withdrawal bleed. Okay, so very analogous to the combined oral contraceptives. You're not going to be giving this to women who are over 35 and smoke. You're not going to be giving this to women with a history of DVT or pulmonary embolism. You're not going to give this to women with super high cholesterol or super high triglycerides. You're not going to give it to women with a history of heart attack or stroke, etc., etc., etc. So here's the patch. It looks just like one of those nicotine patches. I don't think it really matters where you place it, but I do believe that the manufacturer recommends it be placed on the buttocks. Okay, and then finally, we'll talk about the vaginal ring here. Again, this is a combined contraceptive. It's etonogestrel for our progesterone component and ethinyl estradiol. You can see that that's the most common estrogen component in our contraceptives. This is known as the Nuva ring. Now, the Nuva ring, again, here, this is just like any combined contraceptive. You place it for 3 weeks, and then you take it out for a week. Okay, so this is inserted into the vagina, and it's left there. And it's pretty easy. You know, you think about inserting something into the vagina, that might be technically complicated. And this is not like placing an IUD. This is actually quite simple, and a woman is actually typically able to insert it and take it out on her own. So you don't need to place it in the clinic. This is a flexible, as you can see, very flexible ring, and it's inserted up into the vagina. It doesn't really matter the configuration of how it's placed, whatever's comfortable for her. So this just goes up there. I guess this is the ideal placement. Some tips for her: if it's uncomfortable, it's probably because it's not placed far enough. And then Some patients will complain that it's very uncomfortable. Either the woman or the man will complain that it's uncomfortable during sex. In that case, she can take it out, but she needs to put it back in within 4 hours. So that is okay to take it out, but she needs to put it back in. Okay.